I am Neda Gholizadeh from University of Newcastle. I'm happy to present our research on supervised risk predictor of central gland lesions in prostate cancer using proton magnetic resonance spectroscopy imaging with gradient offset independent adiabaticity pulses. Before starting, I would like to acknowledge grant support from Hunter Cancer Research Alliance. Prostate gland is a male reproductive organ that is about the size of walnut found at the base of bladder. Prostate gland has been divided into three zones: central zone, transitional zone, and peripheral zone. Central zone and transitional zone have been upgraded under the term central gland. Almost 70% of the prostate cancer arise in the peripheral zone and 30% in the central gland. For optimal detection and staging of prostate cancer, men with increased prostate-specific antigen level and positive digital rectal exam require an external transrectal ultrasound-guided biopsy. However, low specificity of PSA and low sensitivity of DRE promote MRI as an external method for detection and characterization of the prostate cancer. MRI of the prostate is increasingly popular with the use of multiparametric MRI and prostate imaging reporting and data system classification. MP-MRI based on original PIRATs consists of T2-weighted imaging, diffusion-weighted imaging, dynamic contrast enhancement, and proton magnetic resonance spectroscopy imaging. Conventional MRSI has significant limitations, including moderate signal-to-noise ratio, low spectral resolution, especially at 1.5 Tesla, and non-standardized acquisition techniques. Therefore, MRSI was removed from the last version of PIRATs. However, this version of PIRATs has poor to moderate inter-reader reproducibility, particularly in the central gland, where truss-guided biopsy can produce false negative results. MRSI provides metabolic information such as citrate, choline, creatine, and polyamines, mostly spearmine, from prostate tissue. Due to the difficulty to separate the nearby resonances of choline, spearmine, and creatine, these are often taken together in a ratio to citrate, for example, choline plus spearmine plus creatine per citrate. Point-resolved spectroscopy is the most common pulse sequence for prostate MRSI due to its high signal-to-noise ratio. However, at higher magnetic fields, such as 3 Tesla, PRES has a number of limitations, including chemical shift displacement errors, sensitivity to B1 inhomogeneity, power limitation for wide refocusing spectral bandwidths, and long acquisition times. Recently, a gradient-modulated offset-independent adiabatic with semi-localized adiabatic selective refocusing sequence was introduced to address these problems. The purpose of this study was to evaluate the efficacy of GOIA sLASER pulse sequence in detecting central gland prostate cancer with an external phase array coil, and also to develop risk predictor tools using nonlinear support vector machine classifications for prediction of 4 different groups. In this study, 36 men with biopsy-proven prostate cancer underwent 2-dimensional T2WI in axial, coronal, and sagittal using turbospin echo pulse sequence, DWI using echoplanar imaging sequence, and MRSI using GOIA semi-laser sequence. MRI image was performed on 3 Tesla Prisma scanner using external phase array coil and without endorectal coil. For lesion delineation, radiologists visually matched apparent diffusion coefficient map of DWI, T2WI slice locations, and gland anatomy. A total of 197 cancer regions of interest were manually delineated on T2WI and subdivided into low-risk, intermediate risk, and high-risk cancer groups. Then, 232 normal regions of interest were randomly selected within the remaining central gland. Choline, creatine, citrate, and spearmine level for each voxel were determined by LC model using custom-made GOIA semi-laser base set. The quality of choline, creatine, citrate, and spearmine were measured using Kramer-Rao lower bound, and for normal and cancer tissue were fitted at CRLB less than 30%. Then 3 citrate-base ratio and choline per creatine ratio were determined for each voxel. Additionally, mole fraction ratios of choline, creatine, citrate were evaluated with respect to sum of citrate, creatine, choline, and asparagine. The metabolite information for each multivoxel region of interest was summarized into mean value per each region of interest. Then a non-parametric Mann-Whitney U test was performed with Bonferroni correction to compare the mean value of the following groups. Then binary support vector machine classifications with a radial basis function kernel were developed for different risk groups using citrate-base ratios and all combined ratios with p-value less than 0.05. Kernel parameters were optimized using grid-based method. For each model, voxels were randomly divided into training voxels 80% and testing voxels 20%. This figure is an example of a prostate cancer patient with a high-risk central gland lesion. Figure A shows axial T2WI with low signal intensity on the left side of the central gland. Figure B shows a spectral grid superimposed to T2WI with examples of cancer and healthy voxels. Cancer voxel presented a spectrum with relatively lower citrate and higher choline and creatine signal than normal spectrum. Figure C shows color-coded map of choline plus asparagine plus creatine per citrate in each voxel in the entire volume of interest, which shows high signal intensity for this ratio in the tumor area. This table shows metabolite ratios in cancer and normal tissues. All metabolite ratios except mole fraction of citrate were significantly higher in cancer tissues than normal tissues. Additionally, a significant decrease was observed in mole fraction of citrate in cancer tissues compared to normal tissues. These box plots show significant difference for all metabolite ratios between low-risk versus high-risk cancer group. For low-risk versus intermediate-risk cancer, all citrate-based ratios and mole fraction ratios of choline, creatine, and citrate show significant difference. For intermediate-risk versus high-risk cancer group, all citrate-based ratios and only mole fraction ratio of choline demonstrate significant difference. In terms of risk predictor, normal versus cancer model for all combined metabolite ratios achieved the highest area under ROC curve accuracy, sensitivity, and specificity. Satisfactory results also obtained for low risk versus high risk and low risk versus intermediate risk cancer models. However, the model to separate intermediate risk from high risk cancer tissue obtained the lowest area under ROC curve accuracy, sensitivity, and specificity. To summarize, high-quality prostate MRSI data can be obtained using the GOIA sLASER sequence within clinically acceptable acquisition times using an external phase array coil. This research revealed high accuracy, sensitivity, and specificity for pathological discrimination between normal versus cancer tissue in the central gland. Discrimination between low-risk versus high-risk cancer and low-risk versus intermediate-risk cancer was comparable to studies in which endorectal coils were used.